and many people think of Medicare as outdated and cumbersome. On the other hand, many of us think it's an important tool in the delivery system. Could you both discuss how you see Medicare as a driver of change in our healthcare delivery system? And do you think we'll be better able to effectuate delivery system reform if those changes happen in the care provided to the non-Medicare population by making a public Medicare-like plan available to the under 65 population? And you could also discuss, if you'd like, the difference. The question is, Medicare too low or are private payers too high, which is a half empty, half full. Dr. Fisher, do you want to take the first swing at that?
Sure. Sure. Thank you very much, Congressman Stark. I think Medicare has a very important opportunity to lead because of its size within the country. And I think many of the innovations that are already underway within Medicare around value-based purchasing, around demonstrations on pay for performance, give them powerful leverage to help us learn how to do better and how to do better. On the public plan question, I think if Medicare and the public plan start to adopt the kind of careful payment reforms that we all need to improve the efficiency of care, that could enhance competition. If we have the Medicare program continuing as it is, with essentially fee-for-service payments that are not moving toward value-based purchasing, I don't think it'll be a constructive, that the public plan would be a help in terms of improving the quality and efficiency of care. So I'm relatively agnostic on the public plan. I am very strong about the characteristics of whatever plan we have, whether it's Medicare or the private sector. On the question of the relative, the question about the cost shift, I think it's pretty clear that the issue should not be just prices. That the real problem we have in the Medicare program is on the volume of services, and we have no current good tools to focus on the volume of services. The current model is very much like giving a contractor a per square foot price for the house, but not caring about whether it's 5,000 square feet or 50,000 square feet. You're going to get a mansion if they're allowed to decide how many square feet your house has. So moving toward incentives that promote integration, coordination, and lower costs, regardless of the price, actually helps them have an incentive to be flexible, and you can almost step back and ignore the price, which I think is why we're so encouraged by this notion of accountable care organizations.
Dr. Berenson, want to weigh in on this?
Yes, I would be happy to. As I indicated in my testimony, I think there's some countervailing pressures on Medicare and on a would-be public plan about how they would use their market power to set rates. Clearly, the payer has to assure access to care. And indeed, if there are private plans, at least some providers would be able to give preference to the private plans if, in fact, they were not getting adequately paid in Medicare. Medicare has strived to pay the average reasonable cost, and for the most part, if you look over a long enough period, it sometimes pays a little more, sometimes currently a little less than reasonable cost, but attempts to pay reasonable cost. I don't think that is true in all. I mean, I can say something about Medicaid. Not all Medicaid agencies are trying to do that. There's huge variation across the states in which, in some cases, Medicaid is paying well below cost, and in others, they're attempting to pay nearer to cost. So I guess what I'm suggesting here is that Medicare really does have to find a balance. MedPAC always provides annual surveys to assure, provide some satisfaction that beneficiaries have continued access to care, that providers aren't dropping beneficiaries. And then on the cost shifting issue specifically, it's very complex. I think it's probably a mixture. To some extent, hospitals in particular would attempt to cost shift onto private payers if Medicare had a huge price increase. decrease, I'm sorry. But for the most part, the hospitals that are able to get high prices from plans, here I agree with Glenn, would do so regardless of what Medicare was paying. And indeed, there are some hospitals who, year after year, are able to generate huge end-of-the-line profits, whether they're for-profit technically or not, because they do have that kind of localized market power, regardless of what Medicare payments are doing.